Good day, everyone. Today I will be presenting on the prevalence of syphilis in pregnant women living with HIV from South Africa using a molecular-based assay. To introduce myself, I am Dr. Nonkululeko Mabaso, a postdoctoral research fellow in the School of Clinical Medicine in the University of KwaZulu-Natal. Syphilis is one of the most common sexually transmitted infections, and it remains a significant public health concern, especially in the low and middle income countries, including the sub-Saharan Africa. In 2019, the World Health Organization estimated that approximately 900,000 cases of maternal syphilis and 661,000 cases of congenital syphilis occurred. Recent studies on African pregnant women have reported syphilis prevalence of 1.9% in Nigeria, 3.3% in South Africa, and 5.1% in Ethiopia. Untreated syphilis infections during pregnancy have been associated with adverse pregnancy outcomes such as stillbirths, congenital anomalies, neonatal morbidity, and mortality. In South Africa, point-of-care screening for syphilis is performed routinely as part of the standard antenatal services. This was implemented to reduce adverse outcomes associated with syphilis and improve antenatal healthcare access. The high prevalence of maternal and congenital syphilis has been attributed mainly to inadequate prenatal care worldwide. Other risk factors that have been associated with syphilis include poverty, history of other STIs, HIV infection, history of syphilis in previous pregnancies, low income, and multiple partners. Nucleic acid amplification techniques such as routine PCR, real-time PCR, and nested PCR can be used for the diagnosis of syphilis. However, it is recommended that these techniques may be used as supplemental diagnostic techniques for syphilis screening. The specificity and sensitivity of these techniques differ depending on the stage of syphilis infection and the technique used. In the current study, only vaginal swabs were available for the screening of syphilis by PCR. Therefore, this study aimed to determine the prevalence of syphilis infection in pregnant women living with HIV by PCR. This study also provides data on the risk factors associated with infection, which is currently lacking in our setting. The identification of significant risk factors will assist with the development and implementation of risk reduction interventions. Ethics approval for this study was obtained from the Biomedical Research Ethics Committee of the University of KwaZulu-Natal. This was a cross-sectional study that included 385 pregnant women living with HIV recruited from the antenatal clinic at the King Edward Hospital in Durban, South Africa. The women who were enrolled in this study were 18 years and older, living with HIV, willing to provide a written informed consent, and willing to provide a self-collected vaginal swab sample to be tested for STIs. Each enrolled woman completed the questionnaire on socio-demographic, behavioral, and clinical factors. After collection, each vaginal swab was suspended in 2 mL of PBS. Following vortexing and rinsing in PBS, the swabs were discarded. The remaining suspension was centrifuged at 14,000 RPM for 10 minutes and the supernatant was discarded. The recovered pellets were then subjected to DNA extraction. DNA extraction was performed using the PureLink microbiome kits according to the manufacturer's instructions. The concentration of the extracted DNA was measured using the nanodrop spectrophotometer. PCR amplification was performed on the QuantStudio real-time PCR detection system in a 96-well microtiter reaction plate using the applied biosystems Techman assays. Commercial primers and probes targeting the Pol-A gene of Treponema pallidum were used. Each reaction was performed in a final volume of 10 microliters, consisting of 1 microliter firm-labeled primer or probe mix, 5 microliters of fast start master mix, 1.5 microliters of template DNA, and 2.5 microliters of nuclease-free water. The runs also included a non-template control reaction. The cycling conditions were 1 cycle at 95 degrees Celsius for 30 seconds, followed by 45 cycles of denaturation at 95 degrees Celsius for 3 seconds and annealing at 60 degrees Celsius for 30 seconds. Detection of fluorescent products was performed at the end of the annealing period. Statistical analysis was performed using the IBM SPSS Statistics version 27. Significant testing was performed using the Mann-Whitney U-test for continuous variables, Fisher's exact test for categorical binary variables, and Fisher-Freeman-Halton test for categorical variables with 3 or more levels. The median age of the woman was 30 years, ranging from 25 to 36. A total of 20 over 385 women, which was 5.2%, tested positive for syphilis. The co-infection rate between syphilis and chlamydia was 15%. The same co-infection rate was observed between syphilis and Trichomonas vaginalis. A low co-infection rate of 5% was observed for syphilis and Neisseria gonorrhea. The highest co-infection rate of 25% was observed between syphilis and Mycoplasma genitalium. In the study, none of the sociodemographic factors were significantly associated with syphilis infection. However, of those who tested positive for syphilis, 80% had a high school level of education, 70% were unemployed, and 85% were unmarried. Under behavioral factors, most of the pregnant women who tested positive had a regular sex partner, had partners living with HIV, were not cohabiting with their partners, reported 15 to 20 years as the age of sexual debut, and had circumcised partners. However, all those factors had no statistically significant association with syphilis status. For clinical factors, of the 20 pregnant women who tested positive for syphilis infection, 60% reported STI symptoms such as abnormal vaginal discharge, itching, sores or ulcers, warts, and pain during urination. Having current STI symptoms was significantly associated with testing positive for syphilis with a p-value of 0.03. 65% of the women who tested positive perceived themselves as not being at risk of contracting STIs. The association between risk perception and syphilis status was statistically significant. All the other clinical factors and the presence of other STIs was not significantly associated with testing positive for syphilis. In the unadjusted and adjusted analysis as shown in Table 2, having STI symptoms and risk perception of contracting STIs were significantly associated with testing positive for syphilis. Women who reported having STI symptoms were 2.8 and 3.5 times more likely than those who did not report symptoms to test positive for syphilis in both these analyses, respectively. In comparison to those who did not perceive STI risk, women who perceived themselves as being at risk of contracting STIs were less likely to test positive for syphilis in both the analyses. The other variables were not significantly associated with syphilis infection. Recently, a steady rise has been reported in the prevalence of syphilis among pregnant women. In the study cohorts of pregnant women living with HIV from Durban, South Africa, the prevalence of syphilis by PCR was 5.2%, demonstrating that syphilis infection rates remain high in the South African context. In 2019, the South African National Antenatal Sentinel HIV Survey reported a national prevalence of 2.6 among pregnant women living with and without HIV. Our findings are slightly higher than the prevalence reported by the National Antenatal Sentinel HIV Survey. From the 2019 survey, the prevalence of syphilis in KwaZulu-Natal was 3.2%, with the highest prevalence of 3.8 observed in the Eastern Cape. A study conducted by the NHLS in 2016 to 2017 reported a syphilis prevalence of 3.3% among pregnant women living with HIV. The high prevalence observed in this study may be due to the fact that KwaZulu-Natal is a province where Durban is located and has been shown to have the highest HIV and STI prevalence. All the participants in our study were living with HIV. Therefore, the HIV and syphilis co-infection rate was 5.2%. Our findings are similar to the HIV and syphilis co-infection rates of 5.6% reported by a study conducted by Hoku and colleagues in 2021 on pregnant women from Durban, South Africa. However, Onyangonga and colleagues observed a lower co-infection rate of 1.6% among pregnant women from Durban in the same region. The differences in the syphilis infection rates in these studies may be due to the different diagnostic techniques and the specimen used for testing. In the other studies, syphilis was diagnosed using rapid plasma reagent in blood samples. Although PCR of vaginal swabs was used as a detection method in our study, the findings provide evidence that syphilis infection rates remain high among pregnant women living with HIV in Durban, South Africa. Future studies using serological testing are required in this population to determine the true prevalence of syphilis. In the current study, syphilis was detected using real-time PCR without performing serological testing to detect other stages of syphilis infection. In addition, the use of vaginal swabs for sample collection might have influenced the prevalence observed. The true prevalence of syphilis in this study population may be underestimated due to the low sensitivity of PCR and the use of vaginal swabs. Nonetheless, the high prevalence observed in this study provides evidence that routine screening and intervention programs for syphilis infection are required in this setting. Symptoms of syphilis may be aggravated in people living with HIV. People living with HIV are more likely to have severe clinical manifestations of infection, such as multiple large ulcers. Furthermore, they may have overlapping primary and secondary infections. In the current study, the majority of the women who tested positive for syphilis reported STI symptoms. In this study cohort, the majority of women who considered themselves to be at no risk or low risk of contracting STIs tested positive for syphilis. This provides evidence that the majority of pregnant women had inadequate awareness or knowledge of STIs and risk factors that contributed to contracting STIs. A study assessing the knowledge of STIs and associated factors among pregnant women in Gambia found that 100% of the participants were aware of HIV, 10.4% were aware of gonorrhea, and only 1.1% were aware of syphilis. Another study assessing knowledge, perception of risk, and sexual behaviors in Mozambican women showed that all participants knew about HIV. 87% had heard about gonorrhea, 41% knew about syphilis, and 15% had heard of trichomonas. The low level of risk perception and knowledge of STIs in these studies highlight the need for more effective educational and awareness campaigns about other STIs in addition to HIV. Risk factors associated with STIs have been shown to differ among different population groups and geographic locations. In the current study, syphilis was associated with having STI symptoms and the perceived risk of contracting STIs. Women that reported STI symptoms were 3.5 times more likely to test positive for syphilis infection. This finding suggests that syphilis testing should be performed in pregnant women that report STI symptoms during any stage of pregnancy. Risk perception was also a risk factor significantly associated with testing positive for syphilis. Women who perceived themselves as being at risk of contracting STIs were 76.5% less likely to test positive for syphilis. Surprisingly, women who perceived themselves to be at no or low risk of contracting STIs were more likely to test positive. Previous studies on pregnant women have reported living in a rural or semi-urban area, having one to four previous pregnancies, younger age, illiterate or primary education level, and a positive HIV status as risk factors associated with syphilis. The study had the following limitations. Firstly, the clinical symptoms were self-reported by the study participants. There was no clinical examination by a nurse or physician for clinical symptoms such as genital ulcers, skin rashes, and mucosal lesions. Physical examination and serological testing were only performed by the attending physicians as part of the routine screening in the clinic, and the results were not available for this study reporting. Secondly, the study did not include women living without HIV for comparing the prevalence of syphilis between women living with and without HIV. Lastly, the study only performed PCR testing on vaginal swabs and serological testing was not performed. This might have produced results that underestimate the true syphilis prevalence in the study cohorts. Despite these limitations, the study provides evidence that syphilis prevalence in this population is high. In conclusion, although syphilis testing was performed using vaginal swab PCR in the current study, this study provides evidence that the prevalence of syphilis is high among pregnant women living with HIV from Durban, South Africa. The high percentage of women that reported STIs and tested positive for syphilis indicates that testing should be performed at any stage of pregnancy for symptomatic women. It is evident that women from the study setting have poor knowledge of STIs and low STI risk perception. Educational and awareness programs for pregnant women and other high-risk populations are necessary to improve their STI knowledge, sexual behaviors, and risk perceptions. These are some of the references that were used in this study, and thank you for listening.